Okay, let's start. Okay, friends, I am Dr. Ajay Yadav. So, today we are going to discuss just one short revision. So, just let me see the link if everything is okay. Friends, I am Dr. Ajay Yadav. Okay, seems to be fine. Okay, then we'll go through and whatever your queries, we'll try to take in the end. Fine, so you can post your queries. In the end, I'll try to solve the queries. So, let's start. So let's start with the most basic thing, that is cylinders. And cylinders, so the most important cylinders are used to supply the gases during anesthesia. So what the most important thing about cylinders that you should know? One is the color and second is the pressure. So color of oxygen cylinder, the most important is oxygen cylinder. And the color of oxygen cylinder is black body with white shoulders. So you can see also black body with white shoulders. And pressure in a full oxygen cylinder is 2000 pounds per square inch. So you may find different units in your books also, but forget about that. In India, most commonly we are using is PSI. So it should be 2000 pounds per square inch. Second cylinder in common use is nitrous oxide. Nitrous oxide, which is stored in blue color cylinders. Okay, just a second. Okay, fine. Okay, then. So, what I was telling is pressure in nitrous oxide, the color of nitrous oxide cylinder is blue. You can see also this is nitrous oxide cylinder, blue, and the pressure is 760 pounds per square inch. 760 pounds per square inch. So, there are many cylinders you may see, but the most important which are being used that you must know one is oxygen, which I told you black body with white shoulders. Black body with white shoulders, and the pressure is 2000 pounds per square inch. And second is nitrous oxide, which is blue body, and the pressure is 760 pounds per square inch. But in larger hospitals where consumption of gases is more, we are doing so many cases, it is not possible to change cylinder every time. So therefore, in those centers, these gases, oxygen, nitrous oxide, they are supplied through central supply. You would have seen central supply pipelines also. And through central supply, the gases in India are supplied at a pressure of 60 psi. Maybe in your books you may find answer given is 50 or 55 psi, but in India, the central supply is at a pressure of 60 psi. So you have to mark 60 psi. Now, coming to the important equipments, EMBU bag. EMBU, stands for Artificial Manual Breathing Unit, or actually more popularly, EMBU is a brand name. So therefore, they are called as manual resuscitators. Manual resuscitators. And of course, they are used for resuscitation, for ventilating the patient with this bag. And if you apply oxygen source here and oxygen reservoir here, it is possible to deliver even up to 100% oxygen with EMBO bag. So you can deliver even up to 100% oxygen with EMBO bag. Then Gudel's airway, another very important basic equipment, Gudel's airway. And Gudel's airway is used to prevent tongue fall, because you all know that the most common cause of airway obstruction in unconscious patient is tongue falling back on posterior wall and obstructing the airway. So we place Gudel airway so that this portion of the uterus airway remains between tongue, say this is tongue, and this is posterior pharyngeal wall, thus preventing tongue falling back on posterior pharyngeal wall, thus maintaining the, you can say, patency of airway. Then very, very important device, the most important device is laryngeal mask airway. And you would have seen in every exam, whether it is FMG, NEET, every year you will see a question on laryngeal mask airway, LMA. So LMA, you can say, is a supraglottic device because it is being inserted in the supraglottic area and is being used for ventilation. So you can see the device is like this. There is a tube, and then you can see there is a cuff which is inflated with large volume of air. And these are the ventilation ports which are used for ventilation. So this is LMA. So it is placed blindly in oral cavity so that this portion lies in oropharynx. Now you inflate with large volume of air. So this cuff will get inflated and will seal the oropharynx from all sides. Now, if you ventilate the patient through this tube, if you ventilate the patient through this tube, through these holes, air has no option but to go to larynx. So basically, LMA, when was manufactured, it was manufactured as an emergency device for failed or difficult intubation. But over the years, when we started to use LMA, we found it to be so effective that nowadays we are actually using it for elective ventilation also. So, what are the advantages of LMA? If I compare to intubation, it can avoid complications of intubation. And you know, there are a lot of complications of intubation. So, those complications of intubations can be avoided. Secondly, you can say it is very easy to insert. Even you don't need laryngoscope, it is placed blindly. However, one of the major disadvantage of LMA is, it is not sealing the esophagus. It is just resting above the esophagus. So air can still leak from sides, can enter the esophagus, increase the intragastric pressure, increasing the risk of aspiration. So the major, you can say, disadvantage of LMA is that there is increased risk of aspiration. And another issue is you are clearly seeing that air is getting leaked and patient's stomach is getting distended, but you cannot deflate because to deflate, you need to pass suction catheter Ral's tube. So from where you will pass your suction catheter Ral's tube, because the cuff of LMA has completely occupied the oropharynx or hypopharynx. So you're not able to deflate the stomach also. But this is not problem nowadays because nowadays we are using second generation LMA. And the major advantage of second generation LMA is that there is a separate tube for gastric deflation. There is a separate tube for gastric deflation, and the prototype of this second generation LMA is Procil. So you can see that there is a separate tube for gastric deflation in Procil LMA. So you will pass your suction catheter Ral's tube through this, and through this it will reach, and then it will come out of this hole to enter the esophagus. So you can deflate the stomach. So Procil is the prototype of second generation LMA. Then iGel is again a very commonly used type of laryngeal mask in India. iGel, as the name suggests, it is pre-filled with gel. So you can say instead of this cuff, you need not inflate this cuff with volume of air. It comes pre-filled with the gel. So advantage is that there is no risk of accidental deflation. Otherwise, you can see if there occur accidental deflation, this LMA can move, can touch the larynx, can cause obstruction. So that all cuff related problems can be avoided. And since it's a kind of second generation type, so you can see that there is a separate port from where you can pass your suction catheter Ral's tube, and through this hole, this will enter the esophagus and can lead to gastric deflation. Then LMA Supreme is another type of second generation LMA, and you can see the major advantage of LMA Supreme is that there is a bite block. Otherwise, what can happen? Patient can bite this tube and can lead to obstruction. So this has a proper bite block. You can see LMA Supreme. It has a proper bite block. So chances of biting the tube will not be there. And secondly, you look at the curve. curve is better. So that allows better facilitation. And you can see that it is a second generation. There is a port for stomach deflation. Now, face mask. Face masks are obviously used for ventilating the patient. However, face masks have many disadvantages, and that is why they're only used as a temporary phase till you are able to achieve another better method of ventilation, whether it is laryngeal mask airway or intubation. So, face mask has many disadvantages, like that it requires some expertise to hold the mask. Then it is tiring. But the most important disadvantage of mask ventilation is that if you are providing positive pressure ventilation with mask, air will obviously leak into esophagus, will increase the intragastric pressure, tremendously increasing the risk of aspiration. So risk of aspiration is tremendously increased with mask, and face masks are available in number of sizes, at least 6, 7 sizes face masks are available. Then laryngoscope. Laryngoscope is obviously used to facilitate the intubation. And so laryngoscope is used to facilitate the intubation. There are many type of laryngoscopes which are used based, and they're classified based on the type of the blade they have. The most commonly used is Macintosh. So Macintosh is most commonly used for adults. However, it can be used for pediatric patients also. It's not that we can't use Macintosh for pediatric patients. We can use, but mostly it is used for adults. And the difference is you can see the curved blade. Can you see the shape of the blade? It is curved blade. Then second commonly uses Miller. Miller and Miller you can say is almost a straight blade. So here Macintosh is a curved blade, and here you can say it is straight blade with a little curve at the tip, negligible curve. So basically Miller is preferred for children, but that does not mean that it cannot be used for adults. It can be used for adults also, but generally preferred for children, and I will say children of all ages. Even to a newborn also, you use this Miller. So all age groups, we are using Miller in pediatric age group. For adults, Macintosh. Now, endotracheal tube is definite method of ventilation. It is definite because definitely it is in the trachea and you are directly ventilating the patient through trachea. So it is definitely method of ventilation. And the endotracheal tube which is used nowadays is made up of polyvinyl chloride. So it's a PVC tube, polyvinyl chloride tube. Now, one of the very important component of endotracheal tube is its cuff. So this is endotracheal tube, and this is the cuff which can be inflated with this pilot balloon system. Now, what is the aim of the cuff? Some of you may think that cuff is used for the fixation of the tube, but that's not correct. Cuff is only and only used to prevent aspiration. So to achieve fixation of the tube, you have to fix it nicely at the angle of the mouth. At the angle of the mouth. Now, another very important change which happened is that cuff tube can be used in children at all ages. Previously, less than 10 years, we were not using cuff tubes, believing that cuff tubes can cause subglottic edema or tracheal stenosis. But now it is proven that the cuff material used nowadays is so soft, whether you use cuff tube or uncuffed tube, there is no difference in post-operative subglottic edema or tracheal edema. So therefore, now cuff tube can be used in children at any age. Now, the most important thing about endotracheal intubation is that it should be in the right position. Because if your tube is in esophagus instead of trachea, then you're directly killing the patient. So confirmation of the position of the endotracheal tube is very, very important. And what all you can do to confirm, you can look at the chest expansion. When you are ventilating, chest should expand. Then you should be able to auscultate. There should be adequate breath sounds. But even breath sounds can misguide you. Sometimes the tube may be in the esophagus and you are hearing the conducted sound which you misinterpret as breath sounds. Therefore, surest confirmation of intubation is only possible with capnography. So, capnography is 100% confirmatory. So, capnography, which is the measurement of untidal carbon dioxide or expired carbon dioxide, 100% confirm that the tube is in the trachea. Of course, if the tube is in trachea, then only carbon dioxide will come out of endotracheal tube, which you can measure. So, capnography 100% confirm that the tube is in trachea. Now, so this is all about, see, list is elaborate about the equipment, but these are the very basic, very important that you must know about the equipment which are being used in anesthesia. And obviously, these equipments are also used for resuscitation. So, in accident emergency or wards, if you need to ventilate the patient, resuscitate the patient, you need these equipments. Now, next move to our next section, pre-operative assessment. So you know that we have PAC clinics, pre-anesthesia clinics, where we assess the patient that if the patient is suffering from any medical disease, because based on that, we can plan our anesthesia. And if patient is not medically stable, we can stabilize the patient before considering them for anesthesia. So, a preoperative assessment includes complete history, examination, detailed medical history, surgical history examination, general physical examination, cardiovascular examination, respiratory system examination, like for any other medical patient. What additional thing that we do, that is the airway assessment, because airway management is obviously our responsibility. So we have to assess airway nicely. And one of the very important thing of airway assessment is mouth opening. Because see, we have to intubate the patient through oral cavity. So we will be inserting laryngoscope in the oral cavity and then we can intubate. So there should be adequate mouth opening. And the best gadget that is being used to assess this mouth opening is modified Mallampati scoring. So what we do, we ask the patient to open mouth as wide as possible. And looking at the structure seen, patient has been categorized into 4 categories. So no need to go in the details that which all structures are seen in which category, but simply you can see what we are seeing is fascial pillars, soft palate, uvula, and in fact fauces also, which is the entry point to oropharynx. So you can see in grade 1, all structures are seen. So it means mouth opening is good. We can easily intubate. In class 4, you can see nothing is seen. So nothing is seen means there is no mouth opening. So we will not be able to intubate through oral route. So in that case, either we have to intubate through nasal route, or if that is also not possible, then we may even need to go for tracheostomy. Then another very, very important part of pre-operative assessment is management of the pre-existing drug therapy. Very important. You would have seen that every year they ask question related to this. If the patient is already on some drug therapy, these drugs need to be modified. Certain drugs need to be modified because they can have surgical or anesthetic implications. So drugs which need to be stopped, Viagra or similar drugs, we have to stop 24 hours prior to the surgery. Why? Because these drugs causes sympathetic stimulation and surgery is itself is a sympathetic response. So there is increased risk of arrhythmias. Anticoagulants, particularly anticoagulants means warfarin. There are many anticoagulants, but what you remember is warfarin. Warfarin should be stopped 5 days prior to the surgery. Otherwise, patient can bleed. Then antiplatelets, aspirin need to be stopped 72 hours before surgery. So this is a latest change. So whatever is the very latest change, I will mark it with green pen to give more emphasis on the recent change, because in books you may find different answers. So aspirin we are stopping 72 hours prior. Clopidogrel is the second antiplatelet that is commonly used, available in the brand name Plavis. So clopidogrel, we have to stop 5 days prior. So clopidogrel, we need to stop 5 days prior. Then oral contraceptives. See, high dose estrogen, we need to stop 4 weeks prior because of the increased chances of venous thromboembolism. However, if the patient is on low dose estrogen or only progesterone pills, and nowadays, the latest pills, they are low dose estrogen or only progesterone, that we don't stop, that we continue. Herbal medications need to be stopped 7 days prior. And why green pen? Because previously we were stopping herbal medications at 2 weeks prior, but latest recommendation is to stop herbal medications 7 days prior. AC inhibitors and angiotensin receptor blockers need to be stopped 24 hours. And why again green pen? Because previous recommendation was just to omit the morning dose on the day of the surgery, but nowadays we are stopping a day before surgery, 24 hours before surgery. Smoking need to be stopped 8 weeks prior to the surgery. And why we need to stop smoking so well before, well in advance? 8 weeks means almost, you can say, 2 months, because smoking inhibits cilia, and they say ciliary recovery occurs in 8 weeks. So that's why we have to stop smoking 8 weeks prior, so that there can occur ciliary recovery. Now, morning doses of certain drugs to be omitted: diuretics, particularly if they're not taken for hypertension. If taken for hypertension, we'll continue, else we have to stop. Topical creams, they can have reaction with the antiseptic solutions they are using. So therefore, topical creams also we have to omit on the day of the surgery. Oral hypoglycemics also should be omitted on the day of the surgery. Modifications required for cholinesterase inhibitors. Cholinesterase inhibitors means which drugs? Neostigmine and pardoxtigmine. So what is the modification required? We have to decrease the dose. Why? Because if you stop these drugs, patient can develop myasthenic crisis, because these myasthenic patients are on neostigmine, pardoxtigmine. So if you stop these medications, patient can develop myasthenic crisis, which is a dangerous complication. If you continue, they can antagonize the effect of muscle relaxant. So therefore, we have to find mid path, and mid path is we have to decrease the dose. Steroids, there are a lot of you can say modification parameters which is required, but all those details are not required. Just you can say steroids need to be modified. ATT, what is the modification? That we have to check the LFT, liver function test, because you know that anti-tubercular drugs, they affect liver function test. So if LFT are normal, we can continue. However, if LFT are compromised, then we may need to stop ATT. Monitoring. Monitoring is one of the very essential component of quality care, because it is your monitoring standards which define your quality of care. Quality of care, if your monitoring standards are high, definitely your rate of complications will be less. So starting the CNS monitoring, the most lot of CNS monitoring is required, but the very basic that you should know is the depth of anesthesia. And there are many monitors which can be used to measure the depth of anesthesia. But the most commonly used, and that you also must know, is the bispectral index monitor called as BIS index. And very simple, you can see, you just apply the electrodes over the forehead and attach to the monitor. Automatically, it will calculate the score. And based on the calculation of the score, we can know that the patient is deeply sedated or inadequately sedated, or there is adequate depth of anesthesia. So bispectral index monitor is the most commonly used monitor and really authenticated monitor to see the depth of anesthesia. And then respiratory monitoring. The most basic respiratory monitoring is pulse oximetry, which measures the oxygen saturation, that is SpO2. And the normal value of SpO2, is 97 to 98%, 2 to 3% in the shunt. And pulse oximeter probe is applied in the index finger. It is applied in the index finger. Now, the major disadvantage or limitation of pulse oximetry is that it cannot detect abnormal hemoglobins. So, if the patient is suffering from self-hemoglobin, methemoglobin, or even carboxyhemoglobin, pulse oximeters will not be able to detect. So, they cannot detect abnormal hemoglobin. That's one of the very big limitation. Capnography, one of the very, very important, or I will say the most sensitive respiratory monitor, which give you detail of every breath of the patient. So it is the measurement of expired, or other words you can say end-tidal carbon dioxide. End-tidal carbon dioxide. So we have already discussed that it confirms the intubation, 100% confirmatory. Since it confirmed the intubation, it should be able to detect the accidental extubation. How it confirm intubation? It is measuring the expired carbon dioxide, and carbon dioxide will come out of endotracheal tube only if the tube is in trachea. If the tube is not in trachea, say accidentally extubated, then obviously it will not be able to detect and the carbon dioxide. So that means tube has slipped out of trachea. So detect accidental extubation. So what you expect when the tube is not in trachea, from where CO2 will come? So the value will become zero, and it is graphy, not only the number. It also represents the graph. So there will not be any graph, means the graph will become flat line. So this is what going to happen. See, this is the normal graph of EtCO2. And all of a sudden you see that there is no graph, flat line. So EtCO2 becoming zero instantly means tube has been accidentally came out or slipped into esophagus, extubation. Or there is apnea, means there is no ventilation. So if there is no ventilation, no generation of CO2, so again it will become zero and graph will become flat line. Or tube get disconnected. See, tube is connected to the circuit. So from tube, endotracheal tube, this CO2 will reach the monitor. If it get disconnected, how it will reach? So means disconnected means patient is not getting ventilated. So that is again a life-threatening situation. Complete obstruction. If the endotracheal tube get completely obstructed, then again CO2 will not be able to get exhaled out. So again it's going to become zero. So these are the life-threatening complications: extubation, apnea, tube getting disconnected from circuit, or tube endotracheal tube getting completely obstructed. They are going to kill the patient, which you can see are detected with capnography within seconds in the very next breath. That's why I told you capnography is a very, very important and very sensitive monitor. So this is all about the monitoring. Now you know that anesthesia may be regional anesthesia, means we are blocking one region of the body, or maybe general anesthesia. General anesthesia means we are giving uh, general anesthesia. So you just understand. General anesthesia, we have to make the patient totally unconscious. So that unconsciousness is achieved by IV agents. We give IV agents. And why we prefer IV agents? Because IV agents are ultra fast acting. They will produce unconsciousness within one arm brain circulation time, that is 15 seconds. So you inject, within 15 seconds patient will become unconscious, and that is why intravenous agents, they are used for induction. They are used for induction. Now, so let's discuss a bit about intravenous agents. Thiopentone. Thiopentone used to be used before popularly, but nowadays thiopentone is rarely used, not used commonly nowadays. It has got alkaline pH is 10.4, and the main reason actually for which we are not preferring thiopentone is its long half-life. T half-life is around 10 hours. So we don't want any drug to remain in body for such a long period, anesthetic drug. So that was the main reason for which actually thiopentone is not used nowadays. And it has been replaced completely by propofol. So propofol, you can say, is the most commonly used drug. Most commonly used drug. And the reason again is its half-life. Very short half-life, 2 to 3 hours. Then, but it has got certain disadvantages, like injection is painful. Why? Because it is prepared in soybean oil. So it's an oil-based preparation. So it is prepared in soybean oil. That's why injection is painful. And the second disadvantage, and it's a milky white solution. You can see white solution, milky white solution. And second is there is chances of bacterial contamination with propofol because it contains egg lecithin. And egg lecithin is used as an emulsifier because it's a lipid preparation. And to hold a lipid in circulation, you need emulsifier. So that's why egg lecithin is used as an emulsifier. But the disadvantage of egg lecithin is that egg, is a very good culture media for bacterial growth. So there are chances of bacterial contamination. So therefore, once you have opened the propofol vial, you have to use within 6 hours. Otherwise, after 6 hours, you have to discard. So once you have opened the propofol vial, use within 6 hours, else you have to discard. And I already told you that the biggest disadvantage of propofol is its short half-life, 2 to 3 hours, while that of thiopentone we have seen is 10 hours. And that is the main reason that why propofol has replaced thiopentone. Second, it is a very strong antiemetic. Very strong antiemetic. Another very, very, I will say, unique property is that it is a very strong antiemetic. So it is the IV agent of choice for routine induction. It is IV agent of choice for routine induction we have seen. And it is also very much preferred IV agent for daycare surgeries. Because daycare surgeries, we need agent that has shorter half-life and propofol has shorter half-life. Etomidate is the another IV agent, and the best part of etomidate is its cardiac stability. It is most cardiac stable, but in spite of being most cardiac stable, it is not used routinely because of the possibility of adrenocortical suppression. And you know that once there occur adrenal suppression, it can be a dangerous complication. So therefore, we restrict the use of etomidate only for cardiac patients. Benzodiazepines. Benzodiazepines actually are used in anesthesia either to achieve amnesia or to achieve anxiolysis as pre-medication. And during anesthesia, we are only and only using midazolam because midazolam has shorter half-life. So since midazolam has short life, so therefore that is being used. Ketamine, ketamine, it produces dissociative anesthesia. Means patient get dissociated from himself or herself. So it produces dissociative anesthesia. But ketamine, although it's also not a respiratory depressant or cardiac depressant, but still its uses are restricted for certain situations like say shock. Why? Because it stimulates sympathetic system, so increases the cardiac output. So that is why it is preferred for shock. And the reason why ketamine is not used as a routine because of its vivid reactions, which most commonly manifest as hallucinations. Which most commonly manifest as hallucinations, seen in almost, you can say, half of the patients. Then there can be vivid dreaming, there can be delirium also. And the second disadvantage is that ketamine increases all pressures, increases intraocular pressure, intracranial pressure, or intragastric pressure. So all pressures are increased with ketamine. Opioids. Opioids are used in anesthesia as an analgesic, used for analgesia. And we all know that the major disadvantage of opioids is that there is a risk of respiratory depression. And you all know that the most common cause of death in opioid poisoning is respiratory depression. Then there can be muscle rigidity. So they can cause significant muscle rigidity, and sometimes this muscle rigidity may be so severe in thoracic muscle that the whole thorax become like wood. That is called as wooden chest syndrome. And this maximum muscle rigidity is being reported with alfentanil. Then inhalational agents. So inhalational agents, they are used for maintenance. See, for induction, we use IV agent. So we'll give IV agent, patient will become unconscious. But to maintain anesthesia, we have to use volatile agents continuously given by inhalational route. Why? Because these IV agents, they are metabolized by redistribution. They will reach brain within 15-20 seconds, but they will leave brain within 10 minutes and then get distributed to other body parts, like other body tissues like fat or muscle. So for maintenance, we have to use inhalational agents. So inhalational agents is actually a combination of, I will say, gaseous agent. They may be gaseous agent, or they may be volatile agents. So gaseous agent which is most commonly used is nitrous oxide. Nitrous oxide, which we have seen, is stored in blue color cylinders at a pressure of 760 psi. Now, the most important disadvantage of nitrous oxide is that it is 35 times more soluble than air, or rather, I will say better terminology is nitrogen. 35 times means for 1 mole of nitrogen removed is getting exchanged with 35 molecules of nitrous oxide. Now imagine if there is any air in any of a closed space, like patient is suffering from pneumothorax, pneumomediastinum, pneumopericardium. Imagine for 1 mole of nitrogen removed is getting replaced with 35 molecules of nitrous oxide. So imagine how fast this pneumothorax, pneumomediastinum is going to get converted into tension pneumothorax. Within 10 to 15 minutes, volume can double or triple. So therefore, it is absolutely contraindicated in all these conditions where there is air in any of a closed space. Second disadvantage is ozone depletion. Actually, it's not only the nitrous oxide. All anesthetic gases are responsible for ozone depletion. But since nitrous oxide is used in higher concentration, so that becomes more important. Xenon, xenon, the major advantage is that there is no side effect like nitrous oxide, means no expansion of cavities, and it does not deplete ozone. It's an inert gas. However, cost wise, still you can say xenon is so expensive that we can still say that it is not affordable. It's not affordable. Then volatile agents, halothane. Halothane nowadays is less commonly used. In India, it is still used because of the low cost, but Western countries, it's almost obsolete. There are many reasons, but one important thing about halothane that you must know is that halothane can cause hepatitis, and this hepatitis has got actually autoimmune basis. So this hepatitis has got autoimmune basis. Then isoflurane is the second, you can say, volatile agent that is being used. And the best part of isoflurane is that it is most cardiac stable. And because of this cardiac stability, it is the inhalational agent of choice for cardiac patients. And just now we discussed during IV that which is the most cardiac stable IV agent, etomidate. So for a cardiac patient, for induction, we will use etomidate. And for maintenance, we will be using isoflurane because it is most cardiac stable. Desflurane is a isomer of isoflurane, but it undergoes minimal metabolism, negligible metabolism. And because of the negligible metabolism, it does not produce fluoride. And what's the disadvantage of fluoride? Fluoride can cause nephrotoxicity. So therefore, it does not produces fluoride, so it does not causes nephrotoxicity, making it as a inhalational agent of choice for renal patients. Inhalation agent of choice for renal patients. Sevoflurane, again commonly used, and sevoflurane is the inhalational agent of choice for pediatric induction. Why? Because among the inhalational agents, it has got the smoothest induction. So don't think that for pediatric induction, we prefer induction with the volatile agents. Induction is always preferred with IV, but the problem in children is many times children will come without IV cannulas. So we have to directly induce them by inhalational induction. And in that case, inhalational induction agent of choice will be sevoflurane. Then it is also the inhalational agent of choice for asthma patients. Why? Because it causes maximum bronchodilation. Among all volatile agents, it causes maximum bronchodilation. Then it is also the inhalation agent of choice for neurosurgery. Why? Because it causes minimum increase in intracranial pressure, not intraocular pressure, intracranial tension, ICT. And this I like to use green pen because until recently we were using isoflurane for neurosurgery, but now it has been seen that increase in ICT with sevoflurane is less as compared to isoflurane. Then muscle relaxant. So obviously, you know, for induction we are using IV agents. For maintenance we are using volatile agents. But we need muscle relaxation. So we need muscle relaxation for two purposes: to intubate. How we will intubate if the patient laryngeal pharyngeal muscles are not relaxed? So we need give muscle relaxant to intubate the patient. And secondly, for maintenance of surgical relaxation, surgeon cannot operate if muscle is contracting. So for that also we have to give the muscle relaxant. So muscle relaxants are used for intubation and maintenance of surgical relaxation. And they are broadly classified as depolarizers and non-depolarizers. So depolarizer that is being used is succinylcholine, which is also called as succinylcholine, because it exactly acts like acetylcholine. That's why it is also called as succinylcholine. Now, the major advantage of succinylcholine is its fast onset within 20 to 30 seconds. And duration is also short, within means less than 10 minutes. And because of this fast onset and short duration, it is considered as ideal muscle relaxant for intubation. However, it has many side effects, but these properties makes still this succinylcholine as an ideal muscle relaxant for intubation, short duration and fast onset. But side effect, the most major side effect of succinylcholine is hyperkalemia. And therefore, whatever the pharmacology of succinylcholine revolves, it revolves around hyperkalemia. So that's a, and obviously I told you it acts like acetylcholine. So it will lead to depolarization of all muscles that you can see as fasciculations also, and that releases potassium into circulation, leading to hyperkalemia. And this muscle contraction will also going to cause myalgias. So that also may be seen in half of the patients. Non-depolarizers, which are used, vicuronium. So vicuronium, and the major advantage is most cardiac stable. So most cardiac stable IV agent was etomidate, inhalational agent was isoflurane, and muscle accent is vicuronium. Now atracurium and cisatracurium. Cisatracurium, obviously, as the name suggests, is the isomer of atracurium with less side effects. So definitely cisatracurium comparatively has less side effect as compared to atracurium. Now the unique feature of atracurium and cisatracurium is that they are metabolized spontaneously by Hoffman degradation. So it's a spontaneous degradation. Automatically with the time, they keep on getting degraded. Hoffman degradation. Hoffman degradation means they're not dependent on hepatic functions for their metabolism. So making them as the muscle laxant of choice for hepatic failure. And guaranteed metabolism means there is no risk of accumulation of muscle laxant. So making it also as the muscle laxant of choice for renal failure. So atracurium or cisatracurium are the muscle laxant of choice for hepatic failure and renal failure. And by chance, if you get a question where both cisatracurium and atracurium are given, so of course cisatracurium will be preferred because it has less side effects. Then the block of this non-depolarizer has to be reversed. And to reverse the block, we are using cholinesterase inhibitors, neostigmine. So you know that neostigmine, by inhibiting cholinesterase, acetylcholinesterase, will prevent the degradation of acetylcholine. So there is more acetylcholine available to compete with this muscle relaxant. But the disadvantage is that this increased acetylcholine will also produce muscarinic side effects. So to prevent these muscarinic side effects, we have to give one of the anti-muscarinic drug, that is glycopyrrolate. So when we say about reversal, means we are talking about neostigmine plus glycopyrrolate. So the block of this non-depolarizer should be reversed at the end of the surgery by giving neostigmine plus glycopyrrolate. This is just a repeat slide. So there is a second reversal agent also, that is sugammadex. So sugammadex directly bind to the muscle relaxant. It directly bind to the muscle relaxant and neutralize it. Now just let's discuss a few of the important complications of general anesthesia. Aspiration, which is considered as preventable complication. And what is the best method to prevent aspiration? That keep the patient fasting. So if patient is not full stomach, he will not or she will not be able to aspirate. So fasting is very important. And what are the fasting recommendations? For solid food, we need 6 hours of the fasting. But if the food is fatty and non-vegetarian, then we need 8 hours of the fasting. While clear fluids means water, can be given up to 2 hours. While sometimes the baby, they are on breast milk, they come for surgery. So breast milk can be given up to 4 hours. So if you maintain these fasting hours, you may be able to decrease the chances of aspiration. But sometimes the patients come for emergency surgery. For example, say trauma patient, head injury or laparotomy, bleeding, crush injury, or cesarean patient. Fasting coming for emergency section. So if they are coming and we have to give GA, then the technique that we use is called as a rapid sequence induction. So what the difference in rapid sequence induction from the normal general anesthesia? Here, bag and mask ventilation will be absolutely contraindicated. Otherwise, what will happen? Normally, after giving muscle action, we keep on ventilating the patient with bag and mask till the effect of muscle accent come. But one of the major disadvantage of bag and mask ventilation we have seen, it increases the risk of aspiration. So we cannot give bag and mask ventilation. So bag and mask ventilation is absolutely contraindicated. And secondly, the assistant apply the Kirchhoff pressure, which is called as Salix maneuver. So in Salix maneuver, what the assistant will do, he or she will push the Kirchhoff posteriorly to compress esophagus between his fingers and vertebral column, so patient will not be able to aspirate. Then GI complications can be nausea and vomiting. And nausea vomiting is not only the most common GI complication, overall, it is the most common post-operative complication. And why I'm using green pen? Because previous studies have shown pain to be the most common post-op complication, but the latest study have shown nausea vomiting to be the most common post-operative complication of general anesthesia. Anaphylaxis, any drug that we are using in perioperative period, except volatile agents, can cause anaphylaxis. But the most common cause of anaphylaxis is antibiotics. And I'm again using green pen because previous studies have shown muscle relaxants to be the most common cause of anaphylactic reactions. The latest studies have shown that antibiotics to be the most common cause of anaphylactic reactions. Thermal complications can be hypothermia, but and hyperthermia. And one of the hyperthermia related complications, which is dangerous, is malignant hyperthermia. So, what are the triggering drugs which can trigger malignant hyperthermia during anesthesia? Causative agent, suxamethonium is the most commonly implicated drug to trigger malignant hyperthermia. So suxamethonium is the most commonly implicated drug to trigger malignant hyperthermia. Then volatile agents, they can also cause malignant hyperthermia, all volatile agents. But among volatile agents, maximum malignant hyperthermia is seen with halothane. So overall, maximum chances of malignant hyperthermia are with suxamethonium. However, among the volatile agents, maximally it is seen with halothane. Management, you all know The specific treatment for malignant hyperthermia is dantrolene sodium. So now, after general anesthesia, let's discuss regional anesthesia. Regional anesthesia means blocking one of the region of the body. And to block a region of the body, we have to use local anesthetics. So first, let's understand the property of local anesthetics. Before that, let's see the sequence of nerve blocks, sequence of blockade of nerve fibers. You know that nerve fibers are of ABC type, and the regional anesthesia blocks can be peripheral nerve blocks and central nerve blocks or central axonal block. Central axonal blocks means block given along the central neuraxis, means along the spine. So that includes your spinal and epidural. They are considered as central axonal blocks. So for peripheral nerve blocks, first to be blocked is A fibers, then B, and then C. While for central axonal block, B fibers are blocked earlier than A. So the sequence is BAC, and the recovery is in reverse order. The recovery is in reverse order. And the local aesthetic toxicity, CNS is more sensitive than CVS. So CNS is involved earlier than cardiovascular system. Then local anesthetic with adrenaline must not be used for ring block of finger, toes, penis and pinna, because these structure have end arteries, and using adrenaline in these blocks may lead to gangrene of these structures. So it is contraindicated for ring block of finger, toes, penis or pinna. Important things about the individual local anesthetics, prilocaine. So prilocaine is generally not used. So important thing about prilocaine you can remember is that prilocaine can cause methemoglobinemia. Lignocaine is the most commonly used local anesthetic, and the duration of action of lignocaine without adrenaline is less than 1 hour, that is 45 to 60 minutes. However, when you add adrenaline, you can decrease the systemic absorption, and duration can be increased up to 2 to 3 hours. Maximum safe doses is very important, because if you don't know the maximum safe dose, how you will prevent the toxicity? So maximum safe dose of lignocaine without adrenaline is 4.5 milligram per kg. 4.5 milligram per kg. When you add adrenaline, your safety margin increases. You can give more doses, and you can easily give up to 7 milligram per kg. Second local anesthetic, which is very commonly used, is bupivacaine. And the duration of action of bupivacaine is longer, and bupivacaine is available without adrenaline. So when we are talking about bupivacaine, means plain bupivacaine without adrenaline, and the duration is 2 to 3 hours. And the maximum safe dose is 2 milligram per kg. Cardiotoxicity of bupivacaine really deserves special attention, because it can manifest in any form, ranging from any kind of bradyarrhythmia to any kind of tachyarrhythmia. And ventricular tachycardia is not so infrequent with bupivacaine. And the drug of choice for the treatment of ventricular tachycardia caused by bupivacaine is amiodarone. And why I'm using green pen? Because previously we were preferring bretylium. And the antidote for toxicity of bupivacaine is 20% intralipid. And what does this intralipid do? Simply it bind to the active form of bupivacaine. Now, to decrease the cardiotoxicity, they devised isomers of bupivacaine. So these isomers are the S isomers of bupivacaine, that is levobupivacaine and ropivacaine. And of course, the advantage of levobupivacaine and ropivacaine is that they are less cardiotoxic as compared to bupivacaine. Now, central axonal blocks, that is spinal and epidural. So very important two things in anatomy that you must know. One is the extension of spinal cord. In infants, this spinal cord extends up to the lower border of L3, while in adults, it extends up to the lower border of L1. So what is the significance of this? See, spinal cord in Infants extend up to the lower border of L3. That means when you are giving spinal, you are doing lumbar puncture. Are you going to use L3 for space? No. Because if your needle become capillate, you can cause direct injury to spinal cord. So therefore, you will be using a space below L3, L4, 5 or L5. Similarly, in adults, you will be using any space below L1. Then a very important thing, I say very favorite topic of your FMG, where every year you see this question, what are the structures which are encountered when you are giving spinal anesthesia? So obviously you are entering from the posterior side. So from posterior to anterior, you are entering from the back. So first to be encountered is skin. Below skin is subcutaneous tissue. Then is the supraspinous ligament, which is connecting the tip of the spinous processes, tip of this spinous process. Then intraspinous ligament, which is connecting the spinous process, this intraspinous ligament. Then is the ligamentum flavum. So you can see that, and this is the ligamentum flavum, which is also called as yellow ligament of the body. And after ligamentum flavum, you will enter the dura. And after dura, you will be piercing the arachnoid, because you know that CSF is present in subarachnoid space. So just after, as soon as you pierce the arachnoid, you will see the backflow of CSF, and you can inject your drug. So for spinal anesthesia, drugs which are being used are lignocaine and bupivacaine. However, this lignocaine is not used nowadays because of the possibility of cord-iconic syndrome. So what we are using is bupivacaine, 0.5% hyperbaric. Hyperbaric means this its specific gravity is more than that of CSF, so drug will always try to settle down. Then another sentinel luxal block is epidural. Epidural, we are injecting drug in the extradural space. Epidural space or extradural means outside the dura. Outside the dura means between dura and ligamentum flavum, here, outside the dura, epidural. And the most commonly used needle for epidural is 2-His needle. 2-His needle. Now, what are the contraindications? Very important. You should know that where you cannot do lumbar puncture or you cannot go for central axial blocks. So, contraindications for central axial block, there are many absolute and many relative, but what I'm going to discuss is only the absolute. So, to start with, the most important absolute is raised ICT. Raised ICT you cannot think of. If raised ICT you do lumbar puncture, there will be sudden loss of CSF that can decrease the ICT, and that can lead to coning, uh, or medullary coning can cause immediate death of the patient. Coagulation, if the patient is suffering from some coagulopathies or on some anticoagulants, then you know that if there are traumatic spinal, there will be continuous bleeding, which can cause hematoma, which can compress the spinal cord to cause paraplegia. Patient refusal. If patient is refusing, you cannot give by force. Severe hypovolemia. One of the major disadvantage of spinal or pathophysiological effect of spinal is that it causes lumbar sympathetic block that causes hypotension. So if there is already hypotension, so you cannot give spinal. Infection at local site. Obviously, if there is infection at local site, you cannot introduce infection in the meninges leading to meningitis. Patient having severe fixed cardiac output lesions means say aortic stenosis or mitral stenosis, because these patients will not be able to compensate for their cardiac output. Specialty management, obstetric, very commonly. And patients for obstetrics are coming for cesarean. And cesarean patients, anesthesia of choice beyond any second thought is spinal. Avoid GA as much possible because of the increased risk of aspiration. Actually, a pregnant patient is 4 to 8 times more vulnerable for aspiration because that lower esophageal sphincter is totally incompetent. So avoid GA as much as possible. And if you are giving GA, even if the patient is fasting, she is considered full stomach, and we will always give GA with a rapid sequence induction. I told you that we do for patients who are at high risk of aspiration. Pediatric patients. So pediatric patients, it's not that we cannot give regional anesthesia, but even to give regional anesthesia, we have to give GA. And for GA, I told you induction, already discussed. First method is first preference is always IV, that is propofol. But if IV SS is not available, then the second option is inhalational. And among inhalational, sevoflurane is the first choice. Second and the last choice is halothane. Isoflurane and desflurane, they can never be used for induction because their induction is not smooth. It is very, very irritating. So iso and desflurane can never be used for induction. Daycare surgery, again daycare surgery, we can give GA or we can give regional anesthesia. And in GA, we prefer laryngeal mask, airway over endotracheal tube because intubation have complications. So it is not important whether you are putting LMA or ETT, important is your drug selection. So what IV agent you are going to use for daycare surgery? Short acting, propofol. What opioid you are going to use? Remifentanil, because that is also ultra short acting, metabolized by esterases. Inhalational agent that we prefer is in a sevoflurane. Although desflurane has little faster recovery, because the difference is just 1 to 2 minutes, but it is expensive and irritating. So therefore, we prefer sevoflurane. And muscle accent of choice is mevacurium. Why? Because mevacurium is also metabolized by pseudocholinesterase, so duration is short. And benzodiazepine of choice will be obviously midazolam because midazolam also has short duration of action. Then anesthesia for laparoscopy. You know that the most preferred gas for laparoscopic abdominal insufflation is carbon dioxide because it has got a very high diffusibility. High diffusibility means by chance, say, if it enters pleural cavity or pericardial cavity within 15-20 minutes, it automatically get absorbed from there. However, the ideal gas they say is argon. Why? Because argon is inert. So no systemic side effects. Then a very important thing is when you are insufflating the abdomen, you are increasing the intra-abdominal pressure, and this increase in intra-abdominal pressure can compress the IVC. So therefore, ensure that intra-abdominal pressure remains between 12 to 14 mmHg. This is very important monitoring that you have to do. Critical care, very important oxygen delivery devices. If you would have seen questions for last 3-4 years post-COVID, every exam you will see a question on oxygen delivery devices. So this is what? This is nasal cannula. You can see nasal cannula. This is simple oxygen mask, which may be MC mask, McCartney mask, or also called as Hudson mask. And this is oxygen mask with reservoir. You can see that there is a reservoir bag, this bag, and this is Venturi mask. And different colors of Venturi mask, you can see there are many colors, each color delivering a fixed percentage of oxygen. Now, the most important thing, what should be the maximum oxygen and maximum flows? So with the nasal cannula, maximum flow is 6 liter because at 6 liter you find the maximum output. FiO2 means delivered oxygen concentration of 0.45. 0.45 means you can say around 45%. So after 6 liter, whatever flow you may increase, this oxygen output is not going to go beyond 40%. So you are wasting oxygen. Simple oxygen mask, MC mask or Hudson mask, maximum flow is 10 liters and the maximum output is 0.6, that is 60%. Oxygen mask with reservoir, maximum flow is 15 liter and you can give around 0.8, that is 80% of oxygen. Venturi mask, the maximum flow is 15 liter and at 15 liter, the maximum output is again 0.6, but this point or 60% is comparatively more accurate compared to the other devices. So that's an advantage of Venturi mask. Now, another very important thing is non-invasive ventilation. Invasive ventilation, they don't expect from you, but non-invasive ventilation, it is provided even in accident emergency ward everywhere. And you all know that this non-invasive ventilation, most commonly, it is done for type 2 respiratory failure. So type 2 respiratory failure means COPD or asthma. So these are the most common, you can say, indication for applying non-invasive ventilation means we are giving positive pressure with the mask. So what are the advantages? There is decreased risk of ventilator associated pneumonia, VAP. With intubation, the risk of ventilator associated pneumonia is high. Disadvantages: patient can become claustrophobic with tight fitting mask. And secondly, you are providing positive pressure ventilation with mask, so that is going to increase the risk of aspiration. Now, another very important thing related to critical care is lung protective strategy, because it is not that what kind of ventilator you are using, what mode you are using, what the cost of your ventilator. Patient morbidity and mortality is decided if you are ventilating the patient by lung protective strategy. So, lung protective strategy, one of the most important component is that the patient tidal volume should be low. So, low tidal volume. And the definition of low tidal volume is 4 to 6 ml per kg, not the normal tidal volume is around 10 ml. So we are using low tidal volume, that is 4 to 6 ml per kg of the ideal body weight, not the patient actual body weight. Then plateau pressure should be monitored regularly and it should be less than 30 centimeter of water. Why? Because plateau pressure denotes the pressure at alveolar level. So that is, and so, and barotrauma, happens at the alveolar level. PEEP, we should start with 5 centimeter. PEEP is positive and expiratory pressure. We give positive pressure at the end of expiration so that alveoli remain even during open during expiration and gas exchange can take place even during expiration. But positive pressure even during expiration means continuous positive pressure. So that again will increase the chance of barotrauma. So start with minimum P5 and titrate. So we are protecting the lung against barotrauma. So all these strategies, that is, you are continuously monitoring peak airway pressure, ensuring tidal volume is less, and ensuring PEEP is less. So this will prevent barotrauma. Second thing, you have to prevent the lung against the oxygen toxicity, because hyperoxia can cause irreversible damage. So ensure that FiO2 remains less than 0.6. CPCR, the only thing what I'm going to discuss is the most important change in AHA 2020. And that most important change is in pediatric CPR, that they have changed the respiratory rate from 10 to 20 to 30. Very important change. So previously, for adults and children, per minute, when you are ventilating, we are using 10 breaths. So for adult, still we are using 10 breaths. But for children, this respiratory rate is 20 to 30 per minute. Then another very important change that they made is in the guidelines of intraosseous. Intraosseous means directly injecting into the medullary cavity. And the most preferred medullary cavity, is the upper end of tibia. Although you can use any superficial bone. So what are the changes? It is preferred route for emergency drugs over endotracheal. So if IV is not accessible as an emergency, we can use endotracheal route. But intraosseous is now preferred over endotracheal. Anything can be given. Anything means you can even give blood transfusion through intraosseous route and can be used at any age. Previously, we were using intraosseous only in pediatric patients less than 6 years, but now it can be used at any age. So that is all about. So now let me just go through your queries if there are any. These are what I try my best to cover, whatever is the most important. Now let me just see if there are any specific queries. Okay, let me see what are the queries. Is there any query? Okay, it's only hello, hello, good evening, good evening. Okay, Alfaz Menon says, sir, what about PDF? Okay, I can give PDF, but let me know, Alfaz, how to give, at what, you mean at what link or site I can send this PDF. Sending is no problem. I and but just let me know is if you have any group or something, I can send this PDF. Okay, Alfaz. So just let me know where to send this PDF because it's a YouTube session. So if you have some specific group, just let me know. I can send PDF. Fast relaxation and street free chain. Abhinav Patel, sir, this will be enough for last few revision. I think, Abhinav Patel. See, I cannot say 100% because see, one subject which takes around say 15, 16 hours. So just 1 hour you cannot cover everything. So I try my best. Acha, okay. Okay, Abhinav, I'll send to Yash. Now only I will send, not an issue. I will send to Yash. You can get it from. Nia says you can upload it in description of this video. Okay, I will ask how to do that. I will ask the technical team. Okay, I will ask them to do that. Okay, or I'll send to Yash also and I'll try to upload here also, no issues. And I did not understand fast relaxation and stress free CHN anaphylaxis. I did not understand what are you asking. Can you just please elaborate what you want to ask here? Yeah, Abhinav, exactly in the last you can. So I hope, if not all, so I can say that yes, from anesthesia, 70 to 80% of the questions you'll be able to do with this revision, 60, 70%. Of course, not 100%. So that should be good enough. Okay, then. Any other doubt? No, no one is typing. So I'll just wait for 1 minute. If no one is typing, then I'll close the session. Okay, fine. My best wishes. Okay, good night. So I'm closing the session. Fast relaxation state, sir. Lung protected. Yeah, lung protect strategy. I told you just now. Yeah, lung protect strategy is very important. So I told you about lung protective strategy. That's what you want to ask. Okay. Thank you very much. So I'm just logging out.